Hello and welcome to the Clinical Care Options Medical Specialties Podcast. I'm your host, Robin Black. Today's episode features a conversation between Dr. Joseph Kim from Q Synthesis LLC, Dr. Manish Shah, Clinical Associate Faculty MS1 Preceptor at the University of Florida College of Medicine, and Martha Grugel, MA. They join us today to discuss how to prepare for and manage the prior authorization process for anti-obesity medications to improve the quality of obesity care. You can take home lessons learned on how to deliver a similar project within your practice or institution. For more information on Dr. Kim, Dr. Shaw, and Martha, along with a link to more QI resources, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about this important topic.
Thank you so much, Dr. Shah, for taking the time to speak with us about improving obesity care. And in this interview, we're going to discuss more specifically around the topic of prior authorizations for the anti-obesity medications. So before we start, briefly tell us about yourself, about your practice, and about the patients that you treat there.
Sure. My name is Manish Shah. I'm an internal medicine and pediatric physician. We've had this practice for about 19 years. We see all ages from newborns all the way to great-grandparents. And we've been using anti-obesity medicines pretty much before they were called anti-obesity medicines. So at least for certain classes, and been trying to help patients with their weight loss journeys with diet, exercise, counseling, and also medication. So it's been a nice ride. And most recently, with the advent of some other more powerful medications, we've been very pleasantly surprised with the results. So we're glad to be here.
And tell us about the makeup of the team who work on the prior authorization paperwork and submit all that into the various portals.
So usually it's a combined effort between the medical assistants knowing that they have to get certain codes into the chart, obviously getting a weight every time that the patient comes in, calculating the BMI and entering the BMI codes into the chart. Then the providers recognizing the elevated BMI, it's noticing that it should be a problem that needs to be addressed. And then on the back end of prior authorizations, Martha is our medical assistant, and she catches feedback from the pharmacies as to what additional information needs to be provided, and also proactively gets that information into the chart, or at least reminds us to have certain details into the chart so that those can all be consolidated and compiled so that we can submit them to the insurance companies. Usually she's using websites to get things covered, but now newer websites have come into play from different payers so that we then access those websites and then enter the information there.
So let's talk more about the specifics. Let's describe how the process works for some of those websites that you just mentioned.
Sure, and I'll let Martha actually jump in here.
So they're basically all the same concept. So it's important that when you're submitting your prior authorizations, regardless of which website you're using, that you submit with all of the information required at that time. So you want to attach your chart notes, your BMI for sure, and any comorbidities that they may have, because sometimes that does play into it getting approved or not approved.
The common comorbidities would be the heart disease, sleep apnea,
dyslipidemia
that allow us to bypass certain, or at least pass the bar for certain medications or certain payers. So, and that becomes very handy when we're trying to get these medications covered.
So tell us about the actual workflow process when you're thinking about treating a patient with one of these agents. Kind of walk us through from when you order the medication all the way through to the submission of prior authorization, and just whether it's waiting or communicating with the patient, letting them know, like, how does all of that kind of work?
Sure. So we have a patient with an increased BMI with a comorbidity, say hypertension, heart disease, sleep apnea, or dyslipidemia. We recognize that they probably would benefit from possibly a GLP class of medication. Those usually tend to require the most prior auths. However, we see that also with Wellbutrin and naltrexone as well. So pretty much all of the anti-obesity medications, usually there is some pushback from the payer about whether or not it's going to be approved. And usually it's more, let's make sure that the details are correct, that this is sensible for the patient. So frequently they're confirming that, yes, these comorbidities are there. But on our end, we see the comorbidities, we see the need, and then we approach a patient and say, is it reasonable to discuss your weight if there's something that they've been concerned about? And I would say probably 9 out of 10 patients are very concerned about their weight when we address that issue or approach the topic. And then they say, sure, I'd be more than happy to try something new I've tried. And typically most of the patients, it's not their first rodeo with weight. So they've tried other things in the past. They've tried diet, they've tried exercise, they've tried a lot of different lifestyle modifications to allow them to help them lose weight, but they just don't get past that or they aren't successful. And then they've come to us for usually a different reason, but when we broach the topic of weight, they're more than happy to oblige and say, yeah, maybe there is something I'd be willing to try. And it's important to also document what they've tried. So in terms of what lifestyle modifications are they exercising, how much exercising they're doing, what kind of diets they've tried in the past. We usually try to broach that topic so that we've got kind of a more complete picture of what they've tried before, where they had some shortcomings in terms of success or failures, and then we try to move that needle along with medication. Typically, we do like the GLPs just because they're, I think, pretty easy to use. Once a week injection versus having to take a pill daily. Side effect profile is actually pretty nice in terms of nausea, vomiting, diarrhea, constipation. So they tend to be able to tolerate it better. And in my experience, they're usually able to take it as long as we kind of work with the dosing and stay with low dose and then slowly increase the dose instead of trying to chop off too much at once. So we find that that's been very successful. So we broach that topic as well. Are they willing to do an injection? If they are, then we're usually try to give them a sample of the medication in the office and also have them do an injection here so that they're comfortable with the injection. We run through how to give the injection, and then we actually show them the injection themselves so that they're doing it physically themselves in the office. And I think that overcomes the needle phobia barrier and also the phobia of the medicine and what to do with it when they get home. So they've at least done their first injection. They've already started their journey before they've left the office, which is very powerful for them. So we've got buy-in because they've now done the injections, and usually the medical assistants will walk them through the injections, give them the little time they need and the space they need to do the injections themselves. So that's the first part of the journey. The second part is then picking the medication and sending the prescription out. Now, of course, if they have diabetes, it's different, but if they don't have diabetes, then as long as they have the other risk factors, it's usually easier to get approved, although some insurers will pay for it just strictly for weight loss. So they've got the BMI over 30 or BMI over 40 without risk factors, they typically are getting it approved. So that's if the insurance or if the payers are covering it. So now prescriptions has been sent. Usually then a prior auth notification comes usually by email. And this is usually when Martha kind of gets those. So I'll kind of have her go through those steps from there.
So when we submit the prior authorization, this is where all of that documentation comes into a big factor in your approval process. So when you submit it, it will check their benefits. It asks for your primary diagnosis, which is always going to be the obesity. And then it also asks for a secondary diagnosis, which is important to put their comorbidities if they do have any. And then when you attach, you're always going to want to attach with their BMIs and then office note. So your office note should always have about their diet and exercise, what they've done in the past, because a lot of the insurance companies want to see that they've done some kind of diet and exercise plan within the last 3 to 6 months. And then once you put all of that in there, you submit it, and then that's when we get it back, whether it's approved or not.
And do you find that usually it's instantaneous in terms of the approval process, or do you have to wait a few days?
So it depends on the payer. Some of them, if it's on their list, then some of them are immediately. Some of them take anywhere from 12 to 72 hours.
And you described the process of collecting a lot of the progress notes and other pieces of information. So do you have either any forms, templates, sort of shortcuts on making sure that you've got everything you need prior to submission to ensure that you're not missing anything?
So when we talk to them about their weight loss or their BMI, the providers will usually have a template of everything that they talk about, including the weight loss as far as diet, exercise, things that they've been on in the past. So that will all fall into the note right there.
And then when it comes to explaining to the patient that this medication may or may not be covered and it might take some time, like how do you actually have that discussion with the patient to set their expectations so that they're not surprised?
So we frequently will tell them that we're not sure if the insurance will cover the medication. We usually look for a hint from the EMR with the formulary checker. And if the formulary checker has in our case, a green happy face, it's clear that there is coverage, whether or not that's 100% coverage where they'll be able to just pick it up from the pharmacy right away versus whether or not they're going to need to go through a prior auth. And we kind of prep them that, this is a medication. Unfortunately, it does require usually an authorization. Your insurance will kind of determine whether or not there'll be an authorization. So they know that they may not be getting it right away, but that's also the benefit and the beauty of the sampling, if you can, so that they've already started their medication. So the journey's already started again before they've even filled the prescription, so that they're already on it. Now it's just whether or not the insurance will approve it. It is obviously more frustrating for the patient when they get the or they've already had the medication for 4 weeks and are loving it, and then have to deal with prior authorization process, especially if there's a denial or if there's non-coverage for weight loss. But in general, I think it also then helps them get past the other bar, which is, the insurer, or at least the manufacturers, are now providing the medication at a much lower cost than initial. So somewhere between $400 and $500 out of pocket, which is pretty steep. But at the same time, a lot of patients, after they've tried the medication, see the value in paying that as well. But for the most part, most all of them know that there's going to be a process to get it approved. And we try to approach that before the prescription's written, while the prescription's written, and then of course Martha's on the phone with them after the prescription, after she started on the prior authorization. So in so many ways, a little bit of a team approach where everybody's talking about the same thing, which is, yes, there's going to be a delay, and it's very normal not to be frustrated and not to be dismayed by it. That this is just a process that we know how to work it, and we do.
And in terms of denials as well as appeals or even like a peer-to-peer, do those kinds of things happen within this class of medications? And does that change the results?
It does happen. Usually when it's denied, it's because it's a plan exclusion. So in that case, there's not much we can do when it's a plan exclusion. Sometimes they will get denied, but we've seen recently it's been denied with information giving a website that they want the patient to sign up with through their insurance company for like a diet plan with them. And then once they do that, the insurance sees that they've done it after about 6 weeks. We have been able to resubmit it, and they've gotten approved after they've done that through their insurance company. And then there are some that have denied it, but we've been able to do an appeal as well. Most of those cases it's successful. There are a few that have not been for reasons of the insurance company. Some of the payers want different BMIs. So one may want a BMI of 37 or above before they'll cover it. So that's really the only time we have any trouble.
You've mentioned a number of some of the comorbidities that might impact coverage. Let's just pick one example, for example, like obstructive sleep apnea. Do you find that sometimes patients haven't even been worked up for this potential diagnosis? And if so, is that something that kind of gets into the workflow of determining whether a patient might be eligible for use for treatment with an anti-obesity medication?
Absolutely. And, obviously sleep apnea has its own disease process, and unfortunately it has its own severe consequences as well. So knowing that the patient has sleep apnea is always helpful. Interesting that sometimes we have to consider sleep apnea as a comorbidity if you hadn't diagnosed it before, because you're looking at the same patient for the same reasons. So frequently the patients that are overweight are definitely candidates for having sleep apnea. So yes, it's kind of interesting that we then work up other problems and to get a medication approved. But to be fair, it's also helping the patient out, because if you've got undiagnosed sleep apnea that you have not been treating, then now you've done them somewhat of a favor by saying, hey, look, there is sleep apnea here along with your other concerns, and we probably should address that because it comes with its own long-term consequences.
You've described the process of filling out the prior authorization paperwork, making it sound fairly simple, tedious, and like it requires some time. What would you say are the biggest challenges with actually going through this whole prior authorization process?
I think for us, it is definitely time consuming, I think. And I can let Martha speak to that.
Yeah, I think that's the biggest hurdle is the time consuming because sometimes you do have to get on the phone with them. It's not all just electronic. So sometimes that takes a little bit longer than, of course, anyone would like to do. But other than that, as long as all the documentation is there, it's really a fairly easy process.
For providers, I think, you think about reimbursed time, and obviously you've seen the patient, you've taken care of the patient, written the prescription. I think you've dotted all the I's and crossed all the T's. Then to be asked to provide proof of all that is, I would say, frustrating to say the least. And then on top of that, it does take up staff time. So, and frequently it's every time you give a little bit of staff time, they want a little bit more. So, you finish the prior auth, you've done this, and then the next hurdle appears. So there is a little bit of a cat and mouse game that I feel that we're involved in. And it's obviously a little bit unfair just because it is time that is totally unreimbursed. Obviously, we're doing it for the patient. We wouldn't be doing it otherwise. But it's one of those things that probably will need to be addressed in the near future, that this weight that prior authorizations carry. And it's not just with these medications. Obviously, a whole bunch of other medications have the same issue where you kind of have to prove that the patient needs it. And hopefully we're not prescribing it because they don't need it. So I think that's a future problem that will need to be addressed at some point.
Can you think of an example that was a particularly difficult prior authorization case and sort of how you handled it and what the outcome was?
We did have a recent prior authorization where she was obese and had comorbidities, including, well, the insurance wanted us to prove that she had coronary artery disease in order to pay for the medication. So we did the testing that they wanted, which it showed. And then after submitting that, then they wanted us to prove that she had PAD, which we did an ABI for. And then because that was then like borderline abnormal, we had to send her for additional testing. So it's one of those things where they wanted one thing, we did it and proved it, and now they wanted something else.
And the frustrating thing is for the patients that need it, right? So you have and in her case, it was a positive calcium score, indeterminate PAD screen, and then plus, 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 right? So then now probably an arterial ultrasound to prove the presence or absence of PAD. And then, of course, in the end, the patient is on the sideline saying, well, what else, at this point? And the problem in this particular case was that it was actually previously covered. And then the insurance, as a plan year change, or decided that they weren't going to cover it with the same insurance. So, or it had stipulations for how it would be covered for the following year, which was messy for her because she had been taking it and now had to go off the medication because of cost. So that was definitely frustrating. I think initially we had this issue where people that rightly who should be on the medication were being denied without specific reasons. So, and then we would call on, they would say, well, we'll cover it if you're diabetic. We're like, well, the patient's not diabetic. That's why they're on the weight loss version of this medication. And they said, oh, well, that's right. So you're right. You shouldn't have to say that they're diabetic when they're not diabetic, but we actually don't cover the medicine at all. So it was kind of a cat and mouse game. They would say that you had to pass this or go through this maze, get through the end of that maze. And once you did, then you found out that really it wasn't the fact that they were denying it. It was the fact that, which they could have easily declared, that there was actually no coverage. And so if the issue was that you weren't going to cover it, why make us go through the prior auth process to begin with? So, I get that the payers are trying to figure out their own, landscape with regards to getting the right funds for these medications. But on the flip side, it was kind of like, well, let the doctors go through this mess because they're used to it anyway, and then we'll surprise them at the end, which was, I think, unfair. Yeah, they are going to cover, and we all work hard. The insurers have their things to do. We have our things to do. To play games with that was, I think, inappropriate.
Fortunately, I think these stories have emerged, and we know that they do occur, but hopefully less frequently. So as we think about hiring new staff and training them, as well as teaching them about what's required, fill out the prior authorization paperwork, the forms online, what are the ways, like what are sort of the tips or the strategies in terms of making sure that they don't miss something, ensuring that they're being optimal with time efficiency,
I think that the most important thing is just remembering to attach all of your documentation. You just need one office visit note. So it's really just making sure that when a new staff member comes in, you train them really about the medication itself and what it's used for and what it can be used for. And then everything else kind of just falls into place because like Cover My Meds is very self-explanatory. So it asks the specific questions that you can find in the charting, and then it asks you to upload everything.
And Dr. Shah, any tips for other clinicians out there who perhaps are not documenting as thoroughly or might be missing critical components of documentation to just let them know that, hey, if you're planning on prescribing these kinds of anti-obesity medications, make sure that you include these things in your clinical notes?
So there's two parts of that question. One is sometimes we get to, hey, look, you probably need a weight loss medication a little too early in the conversation. And I think you may want to slow that down just a tiny bit. And I think this is where a template would definitely help to say, hey, now that you decided to start talking about weight loss, you pull in your weight loss template and just run through your questions. Say, are you concerned about your weight? Is it something that we're okay to talk about? What have you tried to lose weight in the past? How much exercise do you get? What things do you think are wrong with your diet currently? Where do you think you're feeling as a patient? If you've got those questions kind of already preloaded so that, when that conversation does come up and you haven't asked those questions ahead of time, you can at least approach that subject a little bit easier and you've got a templated form to just kind of hit your highlights. And then also then you can throw in, is there a history of sleep apnea? Is there a history? Have you had heart disease that you may not have discussed previously? So that those are all in one kind of tidy corner so that when you go to search them, you can find it pretty easily for your prior auth. But it's not all lost afterwards. So, and I tell Martha this all the time, we can always add an addendum, right? That you're not making it up if you call the patient back and say, hey, do you know whether or not you have sleep apnea? Have you ever had a heart attack or have you been diagnosed with coronary disease? You can ask those questions afterwards if you didn't get them the first time, and that's okay. And you can always add it as an addendum. That's definitely legit to do, and it's fair and balanced, and you're not doing anything that's out of the realm of appropriate. So as long as you're not making it up, I think it's totally fair to say, yes, we can add an addendum to that visit, have your medical assistant run through a few questions that will definitely get that information into the chart. And now it's an addendum in the chart. And now you can submit that as your visit. So if you miss it on the first round, I don't think you have to spin your wheels trying to figure out how you're going to get that information into the chart or, gee, I forgot to ask this. An addendum is a perfect way to get that information into the chart. And it's still very valid and accurate.
So, any specific resources or tools that you have found that have really helped in terms of just streamlining the process or just helping guide the prior authorization journey, whether resources from any kind of societies or websites out there, anything like that that comes to mind?
I think it helps to stay up to date with like any of the new recommendations that come in and any new indications that the medications have been approved for. So one of the weight loss medications was just recently approved for sleep apnea. One of them, has been indicated for the CAD and stroke history. So I think as long as you're up to date with that kind of information, that really helps that process.
And it's always a changing landscape, I would say, right? Because as the indications come through, now we have a little bit more to work with the insurance companies to say, no, really, all these things that they have, actually now there's an indication for these medications for these patients. And I will say that insurance companies have been actually fairly responsive. So when the sleep apnea indication came out, I think within a week or two, the insurance companies were allowing coverage for the medications for those particular patients. And when the coronary disease and stroke indications came out, or cardiovascular disease, all-cause MACE came out, that also allowed for some certain patients to get certain medications a little bit quicker. So I think the insurers are, at least the ones that are covering the medicines, are very responsive to the changes in indications. The ones that aren't, unfortunately, aren't. But there's also other ways to get the medication through the manufacturers themselves. So
Is there anything else regarding prior authorization that we haven't discussed that you think would be important to cover?
I think we touch base on a little bit of everything. I think part of it starts in the exam room with getting a reasonable history for weight loss in general, but that's helping you not only with weight loss medications, but also helping you try to where the patient is having the most deficiencies, and that may guide what your treatment is going to be. And it may be that we have patients frequently that come in and say, "Well, when I work on it, I definitely lose weight all by myself." Well, those patients may not need more than a nudge to say, "You know what? Why don't you get back on the exercise bike? Why don't you get back on your diet? Why don't you avoid eating your kids' ice cream when they're having it?" So there are things that you can definitely do that don't necessarily always involve medication, but I think that historical piece really does help you not only get a better idea of where the patient's coming from, which meeting them where they're at is usually, I think, the easiest way to get them to join their weight loss journey or start their weight loss journey. So I think that's very helpful. And it will also help when you're trying to do prior authorizations on the back end. So I think if there's anything I would do a little bit more is actually catch that history early, because that really it gives you a good foundation to start anything that you need to do from there. And it definitely helps your documentation for the weight loss medications down the road too.
Yeah, I think that's the biggest thing is having that documentation. And then, of course, thinking about other things that may relate and help them get it covered. So there's always an option for additional diagnosis codes past your obesity code. So I think including all of that history is the biggest help.
Thank you, Dr. Kim, Dr. Shah, and Martha, and many thanks to you, our listeners, for joining us. As a reminder, to view more QI resources for obesity, please click the link in the show notes. And be sure to check back regularly for more episodes on important medical specialties topics.